Hi, all. I'm Ashley Gearhardt. I am a professor in the psychology department in the clinical area. And my big area of focus is on whether addictive mechanisms are contributing to the intake of nutrient poor ultra processed foods and whether that's important in the impact of chronic diet related disease, but also mental health. And I'm really happy today. The presentation was really pulled together in large part with many of my lab members who have been really doing the nitty gritty on us getting all these technologies integrated into our program of research. I have Dr. Selena Furmans on today. She's a postdoctoral fellow in my lab who's coming to us from the University of Minnesota. Ingrid Worth and Jackie Zhang, who are two post-bac research staff, and they helped really give some guidance on thoughts about what's helpful to know, what did we learn, how have we kind of been pulling this all together. So today I will go ahead and get started, and let's see, one sec here to get the sharing going. Fabulous. All right, can people see my screen? Can you just give me a thumbs up if you can see it? Excellent. So today I'm going to be speaking about our continuous measures of diet, sleep, and physical activity and disease-specific research. And this is coming from our lab, the Food Addiction Science and Treatment Lab here at the Psychology Department. I think we're probably best known because we have a simulated fast food restaurant in the first floor of the Psychology Department. I have to say our French fries in particular are top notch. So we'll bring people into our simulated fast food restaurant as one of our phenotyping approaches and see how that impacts people's craving and desire and motivation to work on things like progressive reinforcement tasks to gain access to different types of food. This is a picture of my lab that includes undergrads, grads, and postdocs. And one of, as I mentioned, our major areas of focus is trying to look at addictive eating behaviors through an addiction lens. And we use multi-method approaches, neuroimaging, behavioral phenotyping, measurement development. And honestly, we're newer to the space of remote method of using EMA and Fitbit and continuous glucose monitoring, some of the things that I'm going to be talking about here. So we're also very open to thoughts or suggestions that people have, and feel free to email me or chat me about anything that pops in your head. So just to give you a sense of some of the content of what I'm going to be talking about relative to the studies where we use some of these methods, is we're really interested in ultra processed foods. And this is a term that's relatively new, but essentially it's a food that has almost no actual food left in it. It's a hyper processed industrial food. Think Oreos, think sodas, think frozen pizza. And they're often incredibly high in added sugars, refined carbs, preservatives, and artificial sweeteners and flavors. There's evidence that they're intentionally designed by the industry to really hook people and make people want more and more and more. And they've really started to explode in the modern food supply since the late 1970s. They've gone from a small sliver of our food supply to now some estimates go up to 73% of the American food supply is ultra processed foods. And this has been linked to a wide array of negative health consequences, from diabetes and heart disease to things like Alzheimer's, cognitive decline, but also some of the strongest evidence for associations with things like depression and anxiety as well. So we're really trying to think about how we fuel our body and how that might play a role in our well-being. We have two studies that I'm going to be using a bit as our archetypes for how we're kind of using different digital technologies to try and enhance our science. We have a food and mood study where we're really focusing on ultra processed foods and depression in this study. And then our study, Ultra Crave, which is a study in R01 I have funded by NIDA, where we're trying to see whether people who consume a lot of ultra processed foods, do they show perhaps a withdrawal syndrome when they try and cut down. So our food and mood study is a study that was funded through the Eisenberg Family Depression Center. We're incredibly grateful for that funding. It really helped us try and hit a novel topic area that attention in has really exploded since we got this grant, in part due to political changes and a lot of focus on food as medicine as a potential avenue in understanding health and well-being. Using our funds from the Eisenberg Family Depression Center, we aimed to understand how ultra-processed food intake contributes to depression and how changing people's dietary patterns in various ways might shift the experience of depression. This study had 31 adults that participated in a 3-week study. They all needed to have moderate to severe depression, and they needed to regularly consume ultra-processed food. That's not hard to find in the United States. Almost everybody's consuming ultra-processed food really regularly. It was a 21-day protocol. We did 7 days where people consumed their typical diet while we collected our measures that I'll go through for you. And then we randomized everybody to one of 2 conditions, interventions to alter their dietary intake. All participants were given instructions to consume a low ultra-processed food diet. 1/3 of them received snacks to help them, but 2/3 we actually partnered with an industry partner that did meal delivery services of low ultra-processed food, and we delivered all their breakfast, lunch, and dinner for 2 weeks to make it particularly user-friendly for someone who's currently experiencing depression to eat a low ultra-processed Mediterranean-style meal. Our other study is the RO1 from the National Institute of Drug Abuse. It aims to determine whether reductions in UP food intake maybe causes aversive withdrawal syndromes in humans, including things like agitation, irritability, depressed mood, also whether it increases motivational salience of ultra-processed food cues in a way that would make it hard to cut down, and whether these factors undermine the ability to really stick to a lower ultra-processed food diet for people who are motivated to eat healthier. We know that. We know most people want to be eating healthier, but the vast majority of people fail when they're trying to change their diet on their own. So this study is ongoing. We're about at the midway point. We're recruiting adults to age 22 to 60 who have symptoms of addictive intake of ultra-processed foods, which if anyone's interested in how you measure that, don't hesitate to shoot me an email. We have a free and easily available scale that's been cited like 1,000 times. So don't hesitate if that's something of interest for you. And that they're regularly consuming ultra-processed foods. This study is a 14-day protocol, 7-day baseline, common diet of ultra-processed food intake, and then they're randomized into one of 3 conditions, either continuing their standard high UPF diet. 1/3 of the group, we say eat low UPF, we give them dietary instructions, and then another third, we give them those instructions. We also give them a week's worth of all their meals to really help them adhere to a low UPF diet so we can see whether the withdrawal syndrome emerges. I'm not going to go into a lot of details about these studies, just wanted to give you a little bit of a sense about what the aims were for us. And now I'll go into what kind of methods, how we were really integrating the digital methodologies into these different studies. So for both studies, we used Fitbit actigraphy as a way to try and get at both physical activity and sleep. We also use Fitbit heart rate measurement in our Ultra Crave study, where we're doing a stress task and we're trying to get at heart rate reactivity. We use continuous blood glucose monitoring in both of these studies, EMA in both of these studies. In Ultra Crave, we use this new methodology called remote food photography method. We use that in our initial participants, but then we no longer used that due to some issues that I'll talk with you about here today. And then we pivoted to a 24-hour dietary recall to capture dietary quality. So it's just kind of a broad overview of the different approaches and methods we've really brought into our study designs. So I'll start with our Fitbit collection and talk about our actigraphy and heart rate goals. Fitbit collects data, as many of you know, on participants' movement, sleep, and heart rate. Both of our studies use Fitbit for actigraphy. We have slightly different versions. Ultra Crave uses the Fitbit Charge 6 watch, and the Food and Mood study uses the Fitbit Charge 5 watch. Both are really similar. We find Charge 6 has a 60% more accurate heart rate sensor and a side button instead of just a touch screen, is what the current current Fitbit data or what Fitbit is currently suggesting. We used the Charge 6 and Food and Mood because it was cheaper than Charge 5 at the time of purchase for that study, and Charge 6 had not been released yet at the time of the Ultra Crave study. So as we all know, what we choose, how we choose it, can always be impacted by what technologies evolved and at what time and what fits in the budget. Our data we use, we upload it to the Fitabase platform whenever the participant syncs their Fitbit. And, we've really been finding that participants are reporting that overall they find the Fitbit really minimally intrusive. It's not something that feels like it's really salient to them or is something that is capturing their attention too much or changing their behavior too much. And this was a much less expensive. We talked a lot with the Depression Center when trying to decide our methods here of different ways to capture this. It's not fully blinded, this approach, but it was a lot less expensive than some other fully blinded actigraphy monitors. So that's also part of the reasons that we went with the Fitbit here. We've, again, found like everything has ups and downs and pros and cons. And our experience, we found that software updates can be a little bit of a headache when those emerge. There's some in-app updates to software, and that can sometimes result in some pretty drastic changes to the layouts and what the participants' experience is. And we have a lot of screenshots and training that we go through with our students or our participants to help them really focus on things. And so this often means we have to do a big reboot of, new screenshots and new training materials. So that's been a bit of a challenge. Again, as we mentioned, all of a sudden a model can be discontinued, right, when we're in the midstream of a study. So, we have a variable in there for all of our different studies about which Fitbit version people have, so we can include that as a potential covariate. And there's some evidence that, there's limitations to the accuracy of certain features. There's some evidence that sleep may not be able to be as accurately measured by a wrist device, and that specifically some questions about whether Fitbit may be overestimating light sleep and underestimating deep sleep compared to, kind of more, kind of invasive or different approaches to measuring sleep quality. We found that participants can miss data if the participants don't charge their Fitbits or forget to put the watch back on. And particularly for our participants, we found, we have some individuals who have really high body mass index and larger body sizes. And so we really have tried to be really thoughtful about having various watch wrist sizes. So, and that way it can be comfortably worn by people with different wrist sizes. So if you are thinking ever of potentially moving into the space of working with participants who might need a larger wrist watch for their Fitbit, we have found that you can purchase those, and that has worked pretty smoothly with participants who've needed that approach. We've also had some lessons learned. We've found that the Fitbit blinding, we couldn't fully blind the device that we had, but during the first visit, we changed the settings in their account so they couldn't see things like notifications to move or step counts or calories burned throughout the data. Our goal for the Fitbit is not an intervention. We know that Fitbits can be an intervention in and of themselves, but we're trying to capture kind of baseline physical activity and sleep, and then how it changes over the course of our different experimental or intervention protocols. So we really wanted to set our Fitbit up in a way that wasn't saliently impacting people to get up and move in a way that they maybe don't typically do. People still can get in there and look in different ways to find some of their information. But it isn't something that is as salient as it would be for a typical Fitbit user through some of the settings that we've shifted to. We've done for our food and mood study based on some feedback from the Depression Center, where participants get to keep their Fitbits as part of their compensation because they are affordable. And so we've done that. And we find that participants really like that. They like getting the Fitbit as compensation. So that's been a nice incentive for us. And we really, really do work with our participants and try and set up our strategies and our training so people are really reminded to plug theirs in, and so we get the most complete data as we can. One of the things that we learned is initially we weren't doing a sleep diary in conjunction with our actigraphy devices. So we weren't getting people to kind of say, oh, I woke up at this point or fell asleep at this point. And again, in talking to different folks in the Depression Center, we've definitely added to our morning EMA reports asking about their own perceptions of sleep and adding a sleep diary to help us process and analyze this data. The other way we're using our Fitbit is as a heart rate monitor to look at specifically heart rate variability in response to a stress task. Uh, we like the Fitbit here. In the past, we've used a little bit more of invasive ways of measuring heart rate. But again, a lot of people coming into our lab have larger body sizes, have experienced a lot of weight stigma. And some of the other approaches where we've done things like put things around people's ribs or had to kind of ask people to lift up their shirt to put different measures on, that a lot of participants reported that experience in and of itself was very aversive and very stressful. And so the Fitbit allows us to not make that salient, not alter people's stress experience just by putting on the method. So the Fitbit has been really nice for us there. This task, we have a 3-minute baseline, a 3-minute task of either a stress exposure or food cue exposure, and then we get 3 minutes of post-task heart rate. To help us get increased heart rate accuracy, we use the workout setting in the Fitbit, and that seems to really increase the rate in which Fitbit is measuring heart rate and improves its accuracy. So in this like acute period where we have the timing, we really need to have these discrete intervals, we really are focused on heart rate changes. We've been upping that heart rate ability to measure through that workout function. It can be a little difficult to get the timing recordings perfectly aligned with our RAs who are kind of measuring the time that they started the baseline or started the task, that they're having to kind of measure that on their end and then link that up with the watch. So that's been something we've had to really train our RAs on how to like really make sure they're really paying attention to the time, and that way we can sync the Fitbit watch with the time in which the different stress intervals are occurring. And we've also struggled sometimes that if you're not really careful, the workout function can time out, especially if people aren't moving that much or aren't having a lot of activity, that can turn off. So those have been a little bit of struggles that we've been able to figure out, and we're happy to talk with people about how we've kind of prepped that and set that up if that would be useful for anyone. So again, don't hesitate to shoot us an email. One of the other measures that we've been doing, and I see Joyce Lee is on the call, and Joyce is like so much more of an expert in this. So if you have continuous glucose monitoring questions, I'll probably ask Joyce to give her thoughts on this. Sorry to put you on the spot, Joyce. But continuous blood glucose monitoring is something that the field is super excited and interested about. To give you a little bit of a sense of it, it is measuring people's, you have this little tiny kind of quarter-sized circular disc that goes into the back of people's arm, and it gives this small, it has this tiny little sensor that does get inserted into the skin, but it can repeatedly be measuring someone's blood glucose levels. And it's been used a lot more in the context of diabetes. That's Joyce's area of focus, to help people in their clinical management to stay in the appropriate range for glucose. But there's starting to be this emerging interest in using this to capture people's dietary intake and dietary consumption. And this is great because humans are absolutely horrifically bad at remembering what they ate. And in studies like ours, where we're really saying, hey, skip out on the sodas and the Oreos and the cookies and the chips that you usually eat, all of which can really spike and crash our blood glucose. And we need to know whether people were adherent to that to really estimate whether our experiments and our interventions are working. We kind of have to rely on people's self-report. Well, there's a hope that maybe CGM might be a way that we might be able to kind of look at whether someone was more or less adherent to our, low ultra-processed food, which should be a more low glycemic diet. To be honest, I think we're some of the first labs who are looking at this. There have been more and more labs using CGM and non-diabetic populations. You don't quite get as much of the same blood glucose spikes and crashes in people with appropriately working insulin response, but there is still evidence that there's important flexibility, important variability, and that it can be really, tied to the diet if you account for appropriate covariates. So this for us is a really exciting new collection for us, a new method for us. And so this CGM, we use the Abbott, the Freestyle Libre Pro from Abbott, although we just found out that that is going to be discontinued. So we'll in the midstream of one of our studies, so we'll need to shift to a new version. But it takes measurements every 15 minutes, provides a detailed, continuous picture of glucose fluctuations. It's small, we can blind it, it's water resistant, and so people can swim or shower, they don't have to take it on and off. It's a super easy application process, so our undergrad RAs with appropriate training can really apply the sensor. We don't need kind of a medical professional there to do it. It lasts 14 days. So you can really get a lot of data with a single sensor. And you can look at the graphs that you can see one here on the slide that can give you this graph for the day and kind of people's fluctuation points and where there's spikes and where there's crashes. And we're really hoping to use this in a way to corroborate our participant reports of yes, I adhered to the diet or no, I didn't, and to also get a sense of their baseline fluctuations in glucose and how that might be related to something like momentary fluctuations in affect, stress, depression symptoms, ultra-processed food cravings. So we're really thrilled to be using this method. So some things to know is that, as we mentioned, models can get discontinued and then you got to figure it out. So we're in midstream for that. The accuracy overall is relatively good. The new versions that are coming out are supposed to be even better, be taking glucose samples even more frequently than 15 minutes. The current data suggests that it appears to be accurate regardless of someone's age or BMI. There are certain areas where it might be more inaccurate for hypoglycemia, that kind of blood crash that people can get into it. It might be more effective at getting kind of the hyper spikes of hypoglycemia. There are some risks to be thoughtful about that we have in, for example, our IRB applications, that for some people, it can cause a little bit of skin irritation when it's being adhered. And this can be particularly true among any participants who have skin conditions such as eczema. And there could be like a teeny tiny bit of pain. We haven't had many participants experience that when applied or when it's shortly removed. And there can be a very small risk of skin infection. So all of these things are things that we have informed consent for our participants about, and we do a lot of training and wash your hands and have on the gloves and all those sorts of things to really help avoid any of these likely occurrences. It can fall off. That's actually been one of our biggest issues, I think, as a team, is that it can fall off if it's not properly applied and reinforced. And this we find to be particularly true during the summer months when participants are sweating more. The adherence can be a little bit trickier. And so, we have set up some different approaches to help that stay on, which I'll tell you about. And there is one other little thing, if you're ever interested in doing this, is the display time on the reader needs to be updated manually since it's not connected to Wi-Fi. So when we did the time changes, it was like, oh gosh, we got to go in and manually go in and change our CGM monitors to make sure the time is matching with all of our EMA and Fitbit data, which is automatically updated. So we found that using skin tack wipes can increase adhesion to the skin. That can help have this skin safe marker to really help it fully dry. We use an overlay unless participants object, and that really prevents it from catching on things like clothing and backpacks. We check the CGM a few hours after its application to ensure that it's reading. And if it isn't for any reason, we'll contact the participant right away since we've sent them on their merry way and they're just going about life, to try and bring them in so we can adjust their CGM. If the CGM fails through issues that weren't caused by something on our end, Abbott's been really great about replacing our CGM monitors, and they'll send you a free one if there was an issue with their device. And we also provide participants a lot of information about how best to maintain their CGM and how to prevent it from falling off. We're happy to share any of these materials about our CGM or how to adhere it or how to, avoid those things in any way if that would be useful. I want to pause just for a second because I've rambled a lot of information at you all so far, and I can't see whether there's anything popping up in the comments through my current screen setup. So I just wanted to pause and see, is there any questions or any hands that anyone's raised that I could respond to before I go on? Victoria, do you happen to see anything in the
There are
comments?
not any
Okay,
questions
great.
in the chat. But if there are questions that people have and they want to put them in the chat, um, I can read those questions.
Sounds great. And again, I'll have time at the end, and anybody who finds something we said interesting or wants our materials or whatever, happy to send it. But just in case there was like 27 comments in the chat and you're all like, why are you ignoring me? I wanted to just pause and make sure that there was nothing, no burning question that needed to be asked. So now I'll move on then to our EMA. We're using EMA in all of these different studies. We're using Life Data is the group that we've been using for our EMA reports. And so, our ecological momentary assessment delivery app, we have wake up reports, random reports, bedtime reports. And then in some of our studies, we've been using things like whenever somebody purchases food, that they'll upload a receipt of what they purchased. And that way we've been able to get some purchase data from people. And also on some of the days on our food and mood study, we had people log the food they consumed each week with a photo and a simple description so we could get a little bit more data information from them. Overall, we found that the pros, it's great to be able to use EMA, the sort of things we're asking about fluctuate so much, the food cravings and the affect and the stress and depressed mood, all of these things we want to capture. It's so exciting to be able to be doing them in real time as people are going about their day-to-day lives. And we're really excited about this opportunity to then link that. Particularly, I can't wait with the blood glucose data and then how that might be impacted by physical activity or sleep. We're just really excited about combining these streams of data. And so we found, that we've noticed some really interesting variability and kind of reactivity to the EMA across our two studies. Our sample for food and mood, that was our study where participants all had to have moderate to severe depression. And in that, we found that relative to our sample where people don't necessarily have depression and are instead dealing with more compulsive intake of ultra-processed foods, that our food and mood depressed participants reported EMA to be more of a burden than our other participants. Some described it more as being tedious or annoying, and some participants have actually made responses to us that really checking in about their mood multiple times through the day can cause them to actually feel worse, like to feel a little bit more low or a little bit more depressed. It kind of made them really realize how often they were feeling depressed or low. And so I think, for us, it's just felt really important to make sure that we're giving people mental health resources and support as needed, especially if our approach here is causing a little bit more reactivity. I also think, one of the lessons that we'll probably learn from that is with samples with depression moving forward, we'll maybe streamline our EMA reports and make them, shorter than we typically do with some of our other populations if the burden feels higher for this population. We've had sometimes some device limitations. The apps will glitch sometimes. We find particularly with Android devices, we've been having a little bit of issues. The Life Data platform can be quite expensive and in some ways a little bit restrictive in how we can set it up. It's not very flexible. We found if we want to ask a question or change a question in midstream, we have to almost create a whole new what they call life pack. And of course, the data output is a behemoth with all of these. Selena, the postdoc, is on here, and Jackie has been doing a lot of our programming around EMA and just like cleaning this data, streamlining this data to get into usable forms has been an undertaking. So if anybody has code or anything from working with life data, I want to share any of your guidance, we would greatly appreciate it. I'm going to pop to this. We also noticed that a lot of our participants, we kind of initially in creating our morning and evening reports, kind of made some assumptions about the general time that we anticipated that people would be going to bed or not. And some people they're waking up at 4, you're not going to bed till 4 a.m. and waking up in the middle of the afternoon. So we've really had to kind of get increased information and have some more flexibility about morning reports and evening reports and the time periods in which they exist. So there's been some lessons learned for us there as well. The next kind of final chunk that I'm going to be talking about here is our food assessment. So for any of you, I'm assuming there's a lot of you on here who don't care as much about what people are eating on any given day at any specific moment. But in general, we just find that humans, like, we're horrible about remembering what we ate. Like even if you asked me what I ate last night for dinner, I would like stare at you blankly for a few minutes. And then if you asked me to like estimate the portion size, like I would just be making something up, honestly, in many ways. And most of our approaches cause a lot of reactivity. And so the field as a whole have really been trying to find new technological approaches to measure people's dietary patterns, dietary intake in a way that's valid, not super burdensome, and not causing a ton of reactivity. And I would say overall, we're still really struggling with that issue. So we were excited to try this new methodology. This is done by one of my colleagues, Corby Martin, who's at Pennington Biomedical. This is such a cool technology and idea where he really, rather than having people kind of write this big diary entry of like, I had a quarter cup of brown rice. He's set up a technology where there's using kind of an EMA, using phones, whether someone's own phone, an iPhone or an Android, where people take a picture of what they're going to eat beforehand, and put this little code, that little like rectangle that gives a sense of scale. And you take a picture of both before you eat and after you eat. And he's created some technology that kind of from the pictures is able to kind of get a sense of diet quality and identify what it is and try to get a sense of how much people ate. So this seems super cool rather than making people go through these long interviews with us. But we actually ended up having to discontinue it after 5 participants after doing some pilot testing. Because what we found is that at least Corby's done it in non kind of eating pathology samples as much as validation data. And we find that our group of more addictive eaters have a really different pattern of food intake. They're not just like sitting down and eating a meal and then like maybe they'll have a snack at 1 o'clock. Our groups of participants that we're finding in general have a really erratic food pattern of intake. Many of them will skip breakfast. They'll kind of graze all day and not necessarily have an acute meal. They'll have like a lot of impulsive snacking. And they were finding that that taking these pictures, if you're just sitting down for a couple meals during the day, setting up the picture before and after might be, less burdensome than you're just kind of grazing on potato chips or cookies throughout the day. Well, then every time you're going to graze, you have to stop and use your executive functioning and set up the picture and take a picture. And that, so our participants just told us they were wildly changing how they ate. And it was essentially an intervention in and of itself. They were not just shifting what they ate, but how they ate. And so for us, it just really wasn't feasible to keep doing this. It made them so much more aware of their food choices. And so that baseline week, we were just trying to get their standard approach to eating as a comparison point to our experiments and interventions. The reactivity was so high. So we dropped that. And we also did have a lot of issues, particularly with Android phones. Like they just really would really, really struggle to work for those folks. And so we shifted to a 24-hour dietary recall. The Nutrition Assessment Laboratory here, this is a good resource for anyone who's interested in diet quality in your studies. And I would give a big shout out for trying to assess more food and diet quality based on everything we're seeing about how, certain Mediterranean sort of diets and low glycemic load diets and high quality diets that really nourish us might not just have impacts on the physical health range, but the mental health range. I really anticipate, especially over the next 4 years, that this might be a huge focus of funding. So for people to think about including diet quality and diet changes in their studies, I think this could be a very hot topic. There is a standardized way of assessing that's considered essentially the gold standard of the options that we do have for assessing diet, which is these 24-hour dietary recalls. This is when someone will be called randomly on a certain day, and a trained dietitian will walk them through what they ate in the last 24 hours. Again, there's going to be some issues with recall and bias, but overall, we found that our participants found that this was a less reactive version, because then in the moment when they were eating, they weren't having to think that like, oh, someone's going to see this or stop and pause. And then the Nutrition Assessment Laboratory, you can contract with them, and their trained dietitians will call and do these 24-hour dietary recalls. So we had our participants do a total of 4 times in our Ultra Crave study, one weekday and one weekend during each of our intervention periods. And it's unscheduled, so participants won't know necessarily when they're going to get this call. They know they're going to get a call, but they're not going to know what day. So it's not going to be like, ooh, I know today is the day they're going to ask me what I ate, and so I'm going to eat super healthy today because somebody might call. They don't really know what day they're going to get that call. So Nutrition Assessment Laboratory, you can find that on the UMich website, can be really helpful if you want to integrate that. And participants are also, log some of their foods to help jog their memories, just to help them kind of remember what they ate. And we have found that participants do still report. I mean, there is no perfect approach in the food realm, that participants will report embarrassment about reporting their eating behaviors, especially our participants who are on the more extreme end of kind of a loss of control, compulsive eating. So it's been really helpful to work with the Nutrition Assessment Laboratory, so they know they're working with a professional, and they're not speaking to the staff who are necessarily going to be doing their assessments to see how the intervention or the experiment went. It's kept very separate. So we hope that that won't have as much carryover effect into the other parts of the study that they're doing. So in sum, we use the Fitbit Charge 5/6 for actigraphy and heart rate. We have the continuous blood glucose monitoring for the Abbott Libre Pro, EMA delivered through this real life app. Food photography method was swapped out for the 24-hour dietary recall. And right now we're totally midstream on how we're going to be aggregating all these measurements and their time courses, which we've checked very closely to make sure the time courses are all on the same link, so we can hopefully bring all this beautiful data together and really time intensive sort of ways where we can look at some sort of cross-labbed sort of approaches, which would be so beautiful. So we're midstream into really tackling this data cleaning. So if anybody does have resources and wants to send them my way, we would gladly enjoy them. Questions I'm happy to take, and my staff did a wonderful job of pulling together some references here. So if you want any, they'll be here on the recording here at the end. I'm happy to email these to people as well.